Welcome, everyone. My name is Chris Lutz, and I am the Executive Vice President of Commercial Operations here at Medi-Lynx. I want to thank all of you for attending the call today. I think you will enjoy the educational topics, and we are very proud to have two of the top key opinion leaders in electrophysiology and cardiology as our speakers today. But before we introduce the speakers, I have the privilege of introducing my colleague, Denise German. Denise German is our Director of Clinical Consulting at Medi-Lynx. Denise holds a Master of Science in Nursing from Tennessee State University and an MBA from the University of Phoenix. And she has an IBHRE certification in electrophysiology and pacing. She has over 20 years of clinical practice experience and has spent many years in the industry specializing in electrophysiology, cardiology, and cardiothoracic surgery. Denise has extensive experience working closely with electrophysiology and cardiology fellowship programs, producing best-in-class educational initiatives. Please join me in welcoming Denise German. Denise?
Thanks, Chris. Hi, and thank you for joining Medi-Lynx this evening for our first of what we hope to become regular educational events discussing the benefits of outpatient arrhythmia diagnostics in the care of your patients. My name is Denise German, and I am the Director of Clinical Consulting here at Medi-Lynx, who is sponsoring this evening's webinar. With all of the uncertainty during this pandemic, the way we practice medicine has had to change practically overnight. With a large percentage of our patients having to be seen virtually, a huge challenge emerged. How to have a meaningful visit with a patient that's not right in front of you, with your stethoscope in hand and the ability for a quick in-office 12-lead EKG. Medi-Lynx realized quickly that we were already prepared to help clinicians meet many of these newfound challenges. For those of you that are familiar with our arrhythmia diagnostic platform, and for those that are not, Medi-Lynx has always provided customers with the option of ship to home for our patients. Our cleaning methods for equipment has always been above and beyond the necessary standards. We also knew that our near real-time online ECG portal would provide our physicians and practitioners the ability to log on and view their patient's EKG data stream 24 hours a day, 7 days a week, during a virtual visit or not. And we knew that our daily compliance checks on patients, ensuring their ECGs are streaming properly, would offer even more assurance for our customers. With these things already in place, Medi-Lynx felt prepared to immediately offer our help to many of the hardest hit areas during this difficult time. We quickly put together a COVID-19 solutions package and reached out to major hospital systems in the Northeast as they were forced to create overflow centers. Because most of these makeshift units were in parts of the hospital where telemetry wasn't available, we supplied them with both pulse oximetry and monitors for our COVID-19 patient solution. And they were able to use our arrhythmia diagnostic platform to monitor these patients wherever they were in the hospitals. We don't know what the coming months or years will bring, but it's very likely that more and more patients will continue to be seen virtually. That's why here at Medi-Lynx, we are so glad to have Dr. John Day from Intermountain Healthcare, Salt Lake City, Utah, and Dr. John Rogers from Scripps Clinic, La Jolla, California, to share how they've transitioned their practices successfully for virtual outpatient arrhythmia management. So join me in welcoming, to start this program, Dr. John Day.
Thank you, Denise. I'm just going to start up my slides here. So this was an interesting topic. As mentioned, I'm at Intermountain Healthcare. I'm based in Salt Lake City, and I'm the acting lead of the heart rhythm services for our multiple hospitals within our healthcare system. So much has changed. You don't need me to tell you that. We're going to try to go through this, what we've done, how we've adapted. There may be some pearls there you may want to incorporate in your own practice, or maybe you may say, well, we don't want to go down that pathway. But anyway, I think you'll get a nice view of what we're doing at Intermountain Healthcare, and then you'll hear what's happening at Scripps. So I'll start off clinic in the post-virus world, and it's a new world. These are my relevant disclosures. I am going to talk about some Apple products, and I lost money on Apple stock in 2018. I'm going to talk about a Cisco product, and I lost money on Cisco in the dot-com crash. So not great at technology investing. So this is our practice. There are 5 ablation hospitals within Intermountain Healthcare, and I'm at Intermountain Medical Center, which is our flagship or our main hospital within our healthcare system. We have 5 EPs in our system, 9 nurse practitioners and PAs. And so between the 5 EPs and the 9 nurse practitioners, PAs, we see a total of 25,000 visits in our arrhythmia clinic each year, and that's 100% only EP clinic, which translates to about 100 patients a day that we run through our clinic. So big clinic, big changes. This is our catchment area. I put a little lightning bolt right about where Salt Lake City is there in Utah, and we draw patients from across the U.S., but especially in the Intermountain states. So we also have to cover patients outside of our local geography. So we had been talking about this, going virtual, having the ability to do telehealth for several years. And in fact, our healthcare system, Intermountain Healthcare, even created a Connect Care system. And so we already had a system in place. We were already working toward it. And we were going to phase it in over the next year, but we had to do it in a day. Well, the problem is it didn't work so well. We couldn't get it to work. We couldn't get it to reliably connect with patients. We had no run-in time. And so our first attempt at going virtual with the lockdown didn't work so well. So what was our plan B? Well, we've been using WebEx for our hospital meetings, Intermountain Healthcare. We have people can tune into our grand rounds from throughout our healthcare system. Same thing for our EP conferences, cardiology conferences. We're very versed with WebEx, so we thought, hey, this would be a great way to do it. Let's move our patients over to WebEx with the lockdown since Plan A didn't work. We thought this would work well, didn't work so well. So Plan B didn't work. So we spent about a day on Plan A, a day on Plan B. Now we had to come up with Plan C. And so we looked out there, what are some HIPAA compliant video visit options? These are some of the HIPAA compliant options out there. Due to one reason or another, some were more complicated. We tried WebEx, as I mentioned, had our clinic front office set up WebEx visits. It was HIPAA compliant, but between our providers and our patients, we just could not make it work reliably. So on day 3 of the lockdown, we had to move to FaceTime and Google Duo. FaceTime was perfect. It solved everything for our iPhone patients. We had them sign a consent since it's not HIPAA compliant. And in the emergency lockdown phase, it worked beautifully from day 1. Google Duo, for those on the Android platform, didn't work as well because they had to download an app. But if they were willing to download an app, and if they knew how to set up an app on their Android phone, it worked beautifully. But our younger patients often didn't want to mess around with downloading an app, and our older patients couldn't figure out how to do it. So not a perfect solution for our Android users. So one of the first issues that came up, so this is day 3 of the lockdown. We are now 100% doing clinic, well, not 100%, but pretty close, doing clinic by either FaceTime or Google Duo. Like I said, we had them sign a consent, so they consented to use a non-HIPAA compliant in this emergency time. One of the biggest concerns that came up with our providers is, what do you want? We're using our own cell phones, and we're calling cell phone to cell phone with these video visits. What do we want to show up on the caller ID? So we created a new Gmail email address that would show up, and then set it up so that if they tried to email us or work through it, they'd get a bounce back to call our office on a landline. For Google Duo, we used as our caller ID our clinic phone number. And then at the end of clinic, each of our providers was instructed to switch your caller ID back to your cell phone so that you couldn't be direct video FaceTime at any time of the day. Well, as you might imagine, I forgot. But the interesting thing is we've been doing clinic this way now for almost 2 months. And I have yet to have a patient that has reached out directly to me from FaceTime or Google Duo, even though I forgot to change the settings. So patients either did not want to show their face by video conferencing us at any time of the day, or they respected our time. Either way, that was a pleasant surprise. But as you might imagine, in a cardiology practice, EP practice, not all of our patients have smartphones, or as I mentioned, either did not want to download Google Duo if they were on an Android, or couldn't figure out how to do a download. So we still had patients on flip phones, rotary dial phones, depending on their age. We found that for the FaceTime users, even our 90-plus-year-old patients, they did not have any difficulties at all with FaceTime. All you have to do is answer the phone. It comes built in, nothing to download. Also through Intermountain, they provided our providers with the same RVU credit as we get for an in-person visit, whether we are doing a video visit or even just audio only. Interestingly, we found that the audio only calls tend to last longer. Perhaps it's something about showing your face that gets patients to the point and makes for a very efficient get to the arrhythmia issues rather than their back pain, their knee pain, and all their other pains. It became a very focused visit, much more efficient than we could have ever predicted. But if it was audio only, sometimes we went down some rabbit holes that took time. So what was the key to these video visits? And that was really, given that we are 100% EP only, all we need is the outpatient ECG monitoring, however you do it. We had already years ago moved to remote monitoring for all of our device patients. So for all of our patients with implantable loop recorders, pacemakers, or ICDs, it was a seamless transmission to go to video visits. For our AFib patients, all of those with iPhones, we encouraged them to get the Apple Watch. Many of our patients, a large percentage of our patients already had the Apple Watch. So that was great for our AFib patients, our post-ablation patients, palpitations. AliveCor cardia monitors, some of our own users had those before the Apple Watch, or our Android patients. So that worked okay. We're still doing Holters, where we'd have patients come into the hospital. And for our event monitors, we just shipped them out, as was mentioned with the AliveCor. We've been shipping out event monitors for a couple of years now, so there was no change in our practice there. And we found that as long as we had an outpatient ECG, we could effectively manage these patients remotely. So for those using Apple Watches or AliveCor, we have a patient portal. We have our own app that Intermountain Healthcare created, and our patients would upload their ECGs prior to clinic. Patients who, with pacers, ICDs, we would do a manual upload right before their visit. So we had the most up-to-date ECG when we were ready to do our video visit. So that worked seamlessly. As far as our Medi-Lynx solution, we've had a partnership. Intermountain Healthcare has had a partnership with Medi-Lynx for many, many years now. As I mentioned, we've been shipping out these monitors for a couple of years, so there was no change in our practice. What's the nice thing is, even our 90-year-old patients, while they may be worried about having this device shipped out to them, we have not had an issue. They've been able to interface with the Medi-Lynx team behind the back, behind what we see. All we know is it works great. Even our 90-year-old plus patients can still do this with us shipping it out to them. Interestingly, with our partnership, our own ECG technicians at Intermountain Medical Center monitor the Medi-Lynx monitors during the day. And somehow, and I don't know how we did it, and I don't know if Medi-Lynx even wants me to say it, we worked out an agreement where they take nights, we take days, our ECG techs love it. So we do all of the monitoring for our entire healthcare system through my hospital here at Intermountain Medical Center during the day. Medi-Lynx picks up nights and weekends. Seems like a great arrangement to me. And that also allows us to have the 24/7 monitoring, also include QT monitoring, especially during this COVID crisis, which provided an added layer of security for our patients on some of those antiarrhythmics. We never really were hit with the COVID crisis, so we didn't have to worry about some of the malaria drugs and long QT, azithromycin, et cetera. They can also provide O2 sats. So we got to Plan C, which was FaceTime, Google Duo. We mastered it on the day we tried. Plan C worked on day 3 of the lockdown. But just as we mastered this, we found that our daily call volumes, we typically field over 200 plus calls a day to our practice, dropped to less than 50, which kind of caught us off guard. If anything, we thought our call volume would go up because they'd be afraid to come into the ERs. Our clinic volumes dropped by 45%, even though we had all of these openings. And so suddenly all of our providers found themselves with all these openings in their schedule. Our daily new referrals, we typically get more than 20 new consults a day to our practice, drop down to just 1, 2, or 3 consults a day. So suddenly we found, even though we mastered video visits by day 3 of the lockdown, suddenly we had no practice. And it wasn't just us. Here's something from the New York Times. Amid the corona crisis, heart and stroke patients go missing. All of our STEMI patients disappeared. All of our AFib patients in the ER disappeared. All the stroke patients disappeared. It was almost as if COVID cured our entire geography of all cardiovascular disease. And in fact, while this flatten the curve was so effective, we did the flatten the curve so that we would have bed available in the hospital if you needed it. Well, it ended up flattening the hospitals. Hospitals are going broke. From the LA Times, thousands of healthcares are laid off or furloughed. NPR, as hospitals lose revenue, more than 1 million healthcare workers lose jobs. From ABC News, even the largest healthcare systems are laying off. In our hospital, we didn't lay anybody. Some of our echo techs were being redeployed in housekeeping. They were cleaning toilets instead of scanning the hearts. Our doctors, I know for EP, we took a big pay cut. So flattening the curve really flattened our healthcare system. So at the end, there was less coronavirus, but now we're finding all of this scar-related VT after having big infarcts at home. We're seeing a lot of patients are coming in with severe heart failure, EF of 10, EF of 20, with a previously normal EF from rapid AFib flutter. All of these AF strokes, they had their strokes at home, and so now we're seeing them in the aftermath. And then a lot of our patients are increasingly foregoing cardioversions, ablations, et cetera, because they lost their jobs. So we solved coronavirus. It was never an issue in Utah. Our hospital was a ghost town, but there was a lot of collateral damage. So now we're up and running with video visits. We figured it out. We've got everything mastered. Now, how do we get our clinic back since all of our patients disappeared in the lockdown? Well, the problem is everybody thought we were crushed by the virus, but in reality, we were sending all of our cardiologists home because there was no work to do. We sent out postcards, letters to all of our established patients. We offered same-day video visits, follow-up visits. We reached out to referring MDs and quickly built up our practice with service, unbelievable service. Call up and you get an instant clinic visit. Fortunately now, our June clinic volumes are now 5% higher than pre-COVID, 5% higher year over year for June. So now we are back. But it was pretty bleak there during the lockdown. So what is my typical day? We are in May of 2020. We are in the state of Utah. Our governor unlocked us he unlocked us for doing procedures again the last week of April, and our state unlocked a couple of weeks ago. So even during the lockdown, I physically went to clinic. I found that I work better. Maybe it's because I have 4 kids and a 4-year-old. Some of our EPs were doing clinic from home. We got to the point I was scheduling a video visit every 10 to 15 minutes. Our medical assistants would do the vitals prior to my visit, gather all the medications. As I mentioned, if they had an Apple Watch or an AliveCore, we would upload their ECG. If they had an implantable device, we would do an upload before the visit. If they had Holters, event monitors, we had those ahead of time. About 25% of my clinic volume right now is in person, 75% video. In March, April, it was only 5% in clinic. And that was only if we needed an ECG, echo, or device check. So now, and then I like with the MAs, they kept me We have scribes. They kept me on task, and we found we were incredibly efficient, far, far, far more efficient with telehealth video visits than I would have ever predicted. So where do patients do video visits? This is actually interesting. This is stuff I'd never thought about. We found that our 65 plus age group uniformly did video visits at home, but many of our patients were doing these clinic visits at their work site. And so we would ask them to find somewhere private, a conference room, etc. Some of our patients tried to do their clinic visits while driving, and we would insist that they pull over for that. Some would do it while shopping. Once again, we'd ask them to find somewhere private, go out to their car, whatever. Some we were doing clinic visits while they were hiking or biking. One was even backcountry skiing. So it really changed the paradigm of what it means to go to the doctors. No longer are you fighting traffic, fighting for a parking spot, getting lost, not finding it. We're doing it wherever, whenever, and patients are on time. There are no delays, and we are on time. So as a side note, in our EP lab, we were only doing emergency cases during the second half of March, and in April, we were able to start elective cases. Even though the governor opened us up at the end of April, it took a week or two to get our cath lab to basically bring all of our employees back. The hospital was empty until May. Miraculously, we have not seen any virus infections among any of my colleagues, even those working in the COVID units. All EP lab cases are COVID tested. If they're intubated, the staff is wearing an N95, et cetera, during intubation, extubation, during EP cases. We have a strict no visitor policy and same-day discharges. So with that in place, we've actually filled up our schedule. We've been very busy here in May. Well, what about clinic in June? So going forward, starting in June, our healthcare system has allowed us to open up in-person visits for anybody starting June 1st. And so we've decided as a practice that we're going to give patients the option, whether they want to do video visits wherever, or if they want to come in and do a traditional visit. We are predicting it's going to be about 50-50. So already our paradigm changed. We were 100% in-person pre-COVID, and I suspect we're going to probably wind up somewhere around 50-50 post-crisis. We're only able to do about a third of our stress echo imaging, and that's really because we've got a 40-minute wait down to scrub the room if we do a stress echo to clean it. Our echoes, we can do full echoes, full PET nuclear, but if we want to run them on a treadmill because of the aerosolization, we've got a 40-minute scrub down wait time, so we can only do a third of the volume. So that's going to change our practice. We are still doing masks in clinic, and we will be doing masks in June. It will still be temperature checks in June for anybody who steps foot into our clinic, and a no visitor policy. So if our patients want visitors, we got to do video visits. If they're okay doing it solo, then they can come and see us in person. And as I mentioned, clinic volumes are now 5% higher in June. So we were already strapped with our providers and schedules over, double, triple booked. So we're going to really be hopping in June. And so really it begs the question, do we need more video visits so we can stay on schedule and see these patients? So summing it all together, I've got 6 lessons that we learned. What have we learned from changing our practice overnight? Number 1, if there's no app download for smartphone, it works best. The iPhone gets a 5-star rating for being able to do it through this virus crisis. The only downside, it's not HIPAA compliant. As I mentioned, we had all of our patients sign a HIPAA consent so that we could communicate this way. But the iPhone worked flawlessly, even on our 90-year-old patients. Interestingly, in our schedules, our providers are chronically running late. Under the traditional model, now all of our providers are running ahead. And so we just kept moving our schedule up. And so that was we had never anticipated that we would be running ahead, sometimes 30 minutes, 40 minutes, 50 minutes, even an hour ahead in clinic. We found that our younger patients loved video visits because they didn't want to mess around with coming to the doctor's office. They wanted to keep on working and not have to take a day off from work. And our older patients liked it because they were holed up at home to avoid the virus. Many of our providers preferred video visits just because they're so efficient. We get to the point and you can do so much more. You can treat so many more patients in the same clinic day. So our patients liked it because they found it was more convenient for them. Number 6, and this is key, we found that at least for an EP-only clinic, and you're going to hear a different view with Dr. Rogers, but with an EP-only clinic where we don't have to put the stethoscope on the patient. We just need to know what are their rhythms and what are their symptoms with the rhythms. So we found there was no disadvantage provided we had ECG monitoring of our patients. So going forward, big 3 questions. Number 1, and this is really going to affect, are we going to remain 50-50, 50% virtual, 50% in person going forward? And that really depends on, number 1, will payers continue to reimburse us for video visits? Number 2, can we still use FaceTime and Google Duo with a HIPAA consent? We found that going cell phone to cell phone was so incredibly efficient. None of our patients missed their visit. We had 100% attendance in our virtual clinics. I mean, you could not have dreamed a more efficient clinic practice. And then the third one is, will the coronavirus be with us forever? In the history of humankind, we have yet to develop a human vaccine for coronavirus. I mean, we're all optimistic it's going to be different this time, but it may not. It may be something going with us forward. And so whether this paradigm is going to shift or not. And so thank you for that. Hopefully, perhaps gave you some ideas, some things of way you may or may not want to structure your clinic going forward. But this time I'm going to turn the time over to Dr. Rogers from Scripps Clinic, and he will share with us the California version of this approach. John, it's all yours.
Great. Thanks a lot, John. I'm just going to share my screen here. Are you able to see my slides? Just want to make sure. You guys able to see my slides? Perfect. Okay. Well, thank you, everybody. It's very nice to be speaking with you and to have you all together for this webinar. I think one of the things that I've missed the most, there's lots of things we all miss, right? And so with this pandemic and our being kind of sheltering in place, one of the things I miss is traveling and meeting physicians, meeting nurses, meeting people all around the country who do what we do and learning from them. Sometimes it's at ACC, it's at HRS, it may be other smaller meetings, but I miss that. So these opportunities I think are really important to stay connected as a medical community, to hear what other people are doing, to hear our experiences. We all have experiences, a lot of which are similar, a lot of the daily ins and outs of things that John mentioned in practice, as far as no visitors and masks and checking temperatures, all those things we're all experiencing across the country, across the globe. But my role at Scripps Clinic is I'm one of the cardiologists there. I serve as the co-chair for the Division of Cardiology and for cardiology for the entire heart hospital that you see an image there. I'm also the director of cardiac pacing and tachyarrhythmia device therapy, so basically over the device clinic and monitoring clinics. I'm part of a single group, Scripps Clinic Medical Group. It's a large multi-specialty medical group in San Diego area covering the entire county. We have over 800 physicians in this multi-specialty group of all different areas. We have 5 hospitals in San Diego County with one of those, the image you saw is the Scripps Previs Cardiovascular Hospital. And then in addition to each of those hospitals having office buildings attached with our group, we also have 9 satellite clinics where we all practice. Within the Division of Cardiology, we have 30 physicians, about 20 fellows, a number of 20 nurse practitioners and physician assistants, all in various either inpatient or outpatient office-based capacity. Within that group, we have 4 electrophysiologists, we have 4 heart failure specialists, and 4 interventional structural specialists. The rest of the group is general cardiology, either specializing in imaging or in lipid management, integrative medicine, sports cardiology, a lot of different areas that we have interest in. And as I mentioned, I direct our EKG lab with ECGs, Holters, and all of our monitoring, as well as our device clinic. Well, the genie's out of the bottle as far as telemedicine. You heard John mention that they have to tell you that within the entire Scripps Clinic medical group of all those physicians, prior to this COVID-19 pandemic, 2% of physicians were involved in telemedicine in some way, shape, or form. I personally had no experience in telemedicine other than calling patients to talk about things, but not of visits per se. With the COVID-19 pandemic, now we're at 90% of us in various adoptions and various. Some have just put their toes in it. Others have dived in head first. But about 90% of us and the physicians and nurse practitioners and PAs are actually doing telemedicine. And you can see on the left side of this graph how there was very few visits as we started the shutdown and lockdown. And you have to realize Scripps had said, well, maybe over a year and a half, we might try a pilot where we get primary care, ambulatory medicine involved with telemedicine, and let's see how it goes. As John told you, basically within 3 days, we were shutting down clinics and going to telemedicine. And there was a growth. There was a pretty logarithmic growth curve for us as the physicians and NPs and PAs. Patients, as John mentioned, struggled a little bit with the video, but they get it. And we've had some patients that came and sat in our parking lot of the clinic because they had internet there and they didn't at home. So they drove to the parking lot for their visit, but didn't come into the building. And we found this out after talking to them. On average, we're daily averaging telemedicine visits about 2,300 a day within our large group. We peaked at about 2,800. As we start to open up a little more, we'll see that we're having less and less of the telemedicine visits, but we're not opened up completely. And what's really telling is that if you look at the month of April, this is just April gross posted ambulatory charges for the first 3 weeks of April, 99.7% of the gross charges were for telemedicine visits, only 0.3% for in-clinic visits. So that pretty much says it all. We all went pretty much telemedicine. If you look just at our experience in cardiology, the gray part of the bar graph is the face-to-face visits. And if you look at when we first started back in mid-March, March 18th, there was more in-office visits. But you can see pretty rapidly how the blue and orange, blue being telephone visits, orange being video visits, just within our division of cardiology, you can see how that progressed to more and more telemedicine. And as it seems like we've flattened the curve, as you've heard so many times, that you'll see the office visits are starting to come back in. I personally prefer the office visit. It's hard to see a patient or not see a patient without listening to their heart, listening to their neck, looking at their neck veins, listening to their lungs, looking at their feet, although I have had patients show me their feet on telemedicine visits, video, to see edema. And I was able to diagnose neck vein distension talking to a patient on their video, so their camera was pretty good. But one of the things we face here in San Diego is we've done a really good job at flattening the curve, but we're starting our COVID numbers increase a little bit now because of spillover from Mexico. We have close to 800 or 900,000 American citizens live south of the border, but they all come across for their health care when they get sick. So a lot of patients, because Mexico does have a lot of cases right now, both in Tijuana and Mexicali, our Imperial Valley, the desert areas, and our southern border, where Scripps Hospital has a hospital down there by the border, are all pretty maxed out. So those patients are starting to come to other hospitals in San Diego. So we are seeing a little bit of a higher number increasing. So we may see this number shift again, where the office visits go down and the telemedicine visits go up. What we've known for a long time, this was a consensus paper from 2015 in Heart Rhythm. We've known for a long time that it's best that we follow our device patients remotely. We have them on remote monitoring, home follow-up, and ideally you'd have 100% of your patients on remote follow-up. We know that it decreases morbidity, mortality, and patients just do better overall, have less inappropriate shocks if we have them on remote monitoring. And we've known that for quite some time. In fact, prior to March 2020, we've had our clinic, which is over 4,000 patients, we've had those patients, 90% of them on remote monitoring, which I thought was doing pretty well. We want 100%, but there's always those holdouts that don't want to be on remote monitoring. We usually would see patients 1 week post-op from their device implant in clinic, 6 to 8 weeks later for other programming, and then an annual in-clinic visit with remote follow-up if the patient so had it. Since March of 2020, we've now pushed harder and have about 95% of patients on remote monitoring. Still going to be those holdouts that just don't want to have a remote monitor or not do it at home. We still see the patients 1 week post-op in clinic unless it was a generator change and we're not worried about any programming issues. Then we might do, if using Dermabond, may have a video visit to see the incision, but usually try to see the patients 1 week post-op in clinic. But the 6 to 8 week visit is now telemedicine. Annual visits for now are telemedicine. And our ICM patients, implantable cardiac monitor patients, since we are remotely following them daily, they're also on more telemedicine visits now than they were. If we look at our scheduled remote transmissions, so scheduled telephone or remote transmissions from home, they increased 40% in May so far. We're not even done compared to March. So we've really been pushing and working with our remote follow-up with our implantable devices. But what about our external cardiac monitors? What about Holters and 7-day and 30-day monitoring? These have always been a vital tool, necessary for general cardiology, electrophysiology, heart failure, internal medicine, and even from hospital discharges. But these have been a vital tool for a very long time. And we are able to stay connected via telemedicine with our patients, that we're not having them come in. They're not wanting to leave their house. They may be sick heart failure patients that have other cardiac issues. But we have to continue to maintain that connection even when we're trying to manage their heart rhythm issues, diagnose their rhythm abnormalities, and assess their symptoms. And we have to do that with outpatient monitoring. And this pandemic, as John told you as well, has presented us with many obstacles to monitoring our patients. First, there's patient reluctance to come into the clinic and physician reluctance to come into the clinic. Physicians may have immunocompromised family members. They themselves may be at higher risk with different comorbidities. So they don't want to come in because they're afraid of getting COVID virus. As John mentioned, this global thing that we've seen of where's the MIs and where's the strokes. People are afraid to come to the hospital. So sometimes patients with this COVID virus, those that are now we're starting to see in the office and we've been talking to on video, they're afraid. They're having more palpitations. They're having more shortness of breath. They have anxiety. In fact, I had a patient tell me yesterday, doctor, let's just say my anxiety's having anxieties, which I get. And they were just afraid to be there. They were afraid to step foot out of their house. A lot of times when patients have anxiety, they have palpitations, they have shortness of breath, they have chest pain. Do we know it's anxiety? Well, we may think we know it's anxiety, but we may need to monitor to make sure they're not having an arrhythmia. We're now faced with potential medications that require ECG monitoring, the use of hydroxychloroquine and zithromycin combinations to monitor the QT interval. So we have that unique situation presented to us. And as you heard Denise mention starting off today, Medi-Lynx has addressed that issue to be able to monitor the QT interval. We have a virus infection that any virus can affect the heart, potentially causing viral cardiomyopathy, myocarditis, and pericarditis. But this virus is also very cardiotoxic. Patients present with arrhythmias. They present with hypoxia. They present with chest pain, pericardial pain. There's a lot of cardiac issues that can occur with this specific virus. And hospitals are becoming overwhelmed by the volume of COVID-19 patients. Now, New York and New Jersey had been overwhelmed. They still have a lot of patients. And we're faced with this obstacle that we now need to think of new ways to monitor these patients. And that's new because most hospitals have not been overwhelmed. The hospital in California has not been overwhelmed, but we now have more patients in the ICU. Our ECMO capacity is maxed out. Won't take too long before our ventilator capacity is maxed out because of this surge we're seeing coming over from south of our border. So what kind of innovations have happened in cardiac rhythm monitoring that have been sparked by this COVID-19 pandemic? Well, you always hear the story that a necessity breeds innovation. Well, prior to this, if you look at prior to this pandemic hitting and before we shut things down, we were home enrolling our monitors probably 20% of the time. Not very often, but it existed. Medi-Lynx had existed even before the virus situation presented itself. But in March, we went up to 30% home enrollment of external monitoring. In April, we went up to 60 to 70%. And it's interesting, as we've opened the clinic more to be able to come back in more with the appropriate precautions of no one in the waiting room, temperature checks, wearing masks, etc., we're back at about 35%. So we didn't stay at high home enrollment for external monitors, meaning we order it in Epic, which is our electronic record, and then our lab, EKG lab, then arranges it for home enrollment. The monitor gets sent to the patient's home. They don't have to wait. They don't have to come back. It's all sent to their home. Other innovations are using these devices, using the Medi-Lynx device for remote telemetry. As you heard Denise said, a couple of hospitals up the Northeast use these monitors as a real-time telemetry with the ability to look at every single heartbeat, use these as a remote telemetry for hospitalized patients when their hospital and their hospital telemetry's capacity was overwhelmed. They also can do that as outpatients. The innovation to be able to not only measure QT interval through the monitoring center, monitoring it and providing alerts to physicians if the QT interval becomes prolonged. Oxygen saturation monitoring and alerts, again, offered in monitoring now when it hadn't been previously. And as Medi-Lynx and others have enhanced and improved their website, their portals, and even some apps for us to be able to view that information as quickly and readily as possible. Going forward, I think the COVID-19 pandemic will likely change how we do things, including monitoring, and probably do so for quite a while. I've seen some models that show San Diego that if we stay at a 50% mitigation, we're going to have a lot of patients going into probably all the way to January. If we're at 70%, we may peak in June and be seeing less and less steady state patients by August. So we're all still trying. But I think going forward that telemedicine is here. The genie's out of the bottle. Some clinicians love it. Some patients love it. Others don't. I don't think I love it, but I see its usefulness in certain circumstances. I think that we will use home enrollment continually. It will continue to play more of a role. And the experience about how successful it's been through monitoring, it will probably stay 30 to 40% in my practice, I think. Some may use it exclusively, especially if there's more rural areas that are farther away from the clinics where patients are followed. We'll always have the need for MCT. That's always going to be there. QTC measurement, monitoring, and alerts. I think this may be something that we find useful going forward for other medications that we're using. You know, we admit people to the hospital for two or 3 days to start Sotalol, Ticasent, other drugs. Not saying that we would use an outpatient monitor only, but it may make us feel better that monitor patients longer than we might normally, or if patients have a propensity to long QT or a genetic long QT that's not evident or manifesting on an ECG, if they have to be put on certain medications. So that may be something we have going for us in the future to use. Oxygen saturation going forward in the future, this may be predictive of worsening disease states like worsening COVID infection. Maybe that's how we determine when people need to come back to the hospital. CHF exacerbations, COPD exacerbations. And I think other data such as going forward, such as temperature, weight, blood pressure, activity, posture, all these either may be sensed or could be entered in to help get a picture of how our patients are doing overall. Future possibilities, we'll imagine a world where an external monitor might be able to measure impedance measurements for heart failure. There may be blood pressure surrogates that a patient doesn't have to check their blood pressure, respiratory rate, even a remote stethoscope, a digital device or remote point-of-care ultrasound where a patient can just hold it to their chest and we can say, move it to the left, move it to the right, and we can see a printout or we can see on the screen what it is that their heart is going through right then. I think going forward, those may be things that we have. This situation will innovate the creation of a lot of these things that we'll all benefit and our patients will all benefit from. So how will I personally go forward in this brave new world of the corona zombie apocalypse? Well, I think my practice is, as John mentioned, he's 100% electrophysiology. My practice is probably about 70% device related, troubleshooting in the office, talking about devices going in the clinic, and about 35% general cardiology. So I think the device clinic, we will always stress strive to reach 100% on remote monitoring. We're at about 95%, which we're happy with, but we wish it would be 100%. I think in-clinic visits will be for post-op checks, programming changes, and alerts for now, but we will use the remote monitoring more and more and more. As far as cardiac rhythm monitoring, I think home enrollments will continue. We'll apply the newer innovations to these COVID patients and other patients requiring these different monitoring situations. I think, in the clinic, with the initial concern of the surge in COVID-19 patients, very few patients were seen in the office, as you saw in that one bar graph I showed you. In May, we started seeing more patients in the office, so this may vary with further surges or resurgences of the virus. I think patients will be given a choice to be, like John said, we will do that as well. They'll be given a choice to be seen via telemedicine video or in person, and try to accommodate the patients as best we can. I think for me, I estimate in the new steady state in the future, whatever that is, that probably 10% of my general practice may be telemedicine related, to go over labs, lipids, blood pressures, imaging, and other things that don't necessarily require every single time they're seen for me to place a stethoscope. I think others in our group, and I think our scripts administratively, is seeing that they think that probably in a grand scale of things, maybe 25% telemedicine eventually, with all comers, not just cardiology. So I think that, we've all had similar experiences. These have been my experiences and my thoughts going forward. But I think, having the ability to have devices that allow us to monitor patients, to be delivered to their home, monitor them remotely, additional conditions and parameters monitored, has been very helpful in the partnership of fighting this virus. And with that, I'll turn it back to Denise.
Thanks, guys, so much. So, both of you, and then let me forth. So the first one is, with the prevalence of AF in our clinic, how do you monitor them remotely? Do you have a set practice?
I guess I'll take the first shot at it. Most of my practice is atrial fibrillation, and so I wish we had a uniform system, but basically we use whatever technology the patient has. Whether they're on the iPhone platform, on the Android platform, or they're on the flip phone platform, we have to have a different strategy for each. For the iPhone platform, the Apple Watch works great. For Android, you're kind of left, the cardio monitor is probably the best option. For those with a flip phone, you got to use the Holter or event monitors. And then we may use event monitors for the iPhone patients or the Android patients if we are particularly concerned about something, if there's syncope, or we want to see the onset, offset of their tachycardia, or there's some clinical question. So we use what they have.
Yeah, I would add, I agree with John. I would also add to that a lot depends on what we're managing in the atrial fibrillation. So if it's a discussion about anticoagulation, that may be one way that they're being monitored. If it's a discussion about rate control, we may use certain technologies like John mentioned. If it's a trying to make the diagnosis, cryptogenic stroke patient, or few and far between palpitations patients, it would all be, and there's symptoms involved, it would all be based on the frequency of their symptoms. So if it's symptoms that are fairly frequent, to get an idea what the patient's dealing with, maybe would use a 30-day monitor if I'm looking for the burden over time to be as accurate as possible. If it's something that is, making decisions about anti-arrhythmia therapy success, or symptoms that if they occur post a cardioversion, post anti-arrhythmia drug therapy ablation, and trying to get a handle on that. Well, may use an implantable cardiac monitors as well. So a lot depends on the patient. Like John said, a lot depends on their ability to use technology, their available technology, and the type of AFib, let's just say, or the classification, whether it's paroxysmal, persistent, chronic, what have you, or if we're trying to assess, are we slowing them down too much? Are we slowing them down enough? Are we successful at treating their AFib, along with the conversations with them? So it depends on a lot of different things, but there's a lot of different tools in your toolbox to be able to do that.
Okay, so next question. Coming from an area that has used hydroxychloroquine for COVID, do you see continued use for these patients, or are there other options?
There's so much mixed information that's out there in society right now. We have some studies that say it's not helpful, it could be harmful. We have small studies from around the world saying we think this is helpful, and we have our president saying he's taking it just because. And so, I'm not meaning to be political, but that seriously, prescription requests went up dramatically after that news conference. And I think that, again, the discussions that we used to have in live meetings and would have been having at HRS this year about, what people's experiences are. So these are not treatments to cure the virus. They're not treatments to kill the virus, treatments to eliminate the virus. These are types of treatments that have been used to decrease maybe the replication of RNA genetically, or how it affects the cells, and that people may have less severe of a course, but it doesn't seem to be totally consistent. So there's other antiviral or other drugs that are being looked at. I think the bottom line is there really is nothing proven to cure this, to make people get less sick, but we're seeing anecdotally, or even a little more than anecdotally, a lot of people talking about how helpful it is to keep people from being much more sick, they think. So places that use it quite frequently talk about much less lower mortality numbers. Yet when we try to look at that study-wise, it's not exactly reproducible.
Yeah, I think just with the newer technologies, and we talked a little bit about, so for example, the new solution from Medi-Lynx, I think it just gives you more options. Whether you're monitoring QT with hydroxychloroquine or sotalol, dofetilide, it just gives you more options, more things that you can look at, better ways of monitoring patients. And who knows, maybe it may change the way we approach all of this going forward.
Thanks. So the next one is to both of you. It says, do each of you have set telehealth flowcharts for your patients that you follow?
A set flowchart. I don't know that we have a set flowchart. We schedule them, and it appears on my clinic schedule. And whether it's video or in person, we just do the typical clinic visit and the typical follow-up structure. If we want to see a patient back in 3 months, we'll see them back in 3 months. If it's something that has to be done in the office, then we specify they come into the office. If it's something that could go either way, then we leave it up to the patient, whether they want to do their 3-month post-AF ablation visit virtually or in person later this summer. So we don't have any. It's all the same to us.
Yeah, I agree. We've left it up to each individual physician and NP and PA to make the decision who should be actually seen in the clinic and who should be seen on telemedicine. For a while, it was just about everybody telemedicine. For a couple of doctors in my practice that have issues either with family at home or what have you, that they're at higher risk. One of my colleagues hasn't even left his house since we went on lockdown. And so it's very individualized. I was told, my administration was supportive to me and told me, you get to make the call, you make the decision. So we don't have a flow chart as far as who comes in, who doesn't. We make that decision based individually. For example, if we see noise on an ICD lead, that can't be managed remotely. Now, there are devices that are coming out that are the next generation of devices coming out, even if ICDs are going to be remotely programmable. So we might be able to do some initial visit remotely with that type of situation with implantable devices. But we still need to now bring those people in, do what we need to do to protect them from getting inappropriate shocks and to make sure they're protected appropriately, and then get them set up for the operating room. If it's a battery reaching ERI, end of recommended battery life, and we need to talk about, okay, at the beginning of this outbreak in February, people said, I'm scared, I don't want to come in. I know I just tripped the elected replacement indicator, which means you still have about 3 months left on the battery, but then all of a sudden it's now 3 months later and they're still not wanting to come in. That's all telemedicine to say, we need you to come in and you're pacemaker dependent. I don't even like waiting 3 months. We have to get you into surgery. That can be telemedicine to set up for the surgery. But so it's, people actively having chest pain, if they're brave enough to say, I want to come to the doctor right now, we need to see them in person most likely. And so it's right now at our institution, it's left up to the physician to make the choice. My nurse practitioner, who was in my outpatient practice with me, she and I make those decisions together, talking about each patient that we're dealing with. So some places may have flow charts that say, if you're this or this, you can have telemedicine, or you're this or this issue going on, you may have to be seen in person. It's going to be probably different everywhere.
Thanks. So next question. What would be your expert advice on how to manage and monitor patients safely and give extra cardiac care during post-COVID-19 to cardios and EPs around the world? So cardiologists and EPs around the world is what it's saying. What would be your expert advice on how to manage and monitor patients safely and give extra cardiac care during post-COVID-19 cardiologists and EPs around the world?
I think that there's going to be somewhere between the way it used to be and somewhere in between the way it is now. And I think that we'll have all these tools that we've always had, but we may think about them differently and use them differently as far as going forward monitoring our patients. I think that some areas that have been harder hit, Italy, northern Italy, New York, New Jersey, they're going to take a little bit longer to get back on their feet, but they're pretty resilient people, and I think that they're going to be able to do it, and they're going to go back to some hybrid between what they used to do and what they do now. Now, that said, we still have a lot to learn about this virus, and we still have a lot to learn about how it affects the heart, and we still have a lot to learn about how viral myocarditis and pericarditis and cardiomyopathy is going to play out that's been caused by this virus. We know that people can be suddenly looking better on the ventilator, and then they crash because their echo, which was normal on admission, they have a myocardial, maybe it's the side, maybe it's direct viral, and we don't know. We don't know everything there is to know about this yet, but we will learn it very fast. And I think although social media is kind of a love-hate thing with me, it's how we're getting the word out around the world now. A lot of the information we're learning comes from people talking on social media. If you get rid of the snarkiness, at least the social media education part of it, I thought has been very helpful to help all of us around the world.
Yeah, it's amazing how ingenious everyone is getting. And I think where there's a need, we will find solutions. And as has been mentioned, is our practices will change. It won't be how it was a month or two ago, but it also won't be how it was pre-virus. It's going to be a new world. And I think we'll all find the right balance and what needs to be done to safely take care of our patients. And telemedicine is here.
Okay, so last question that I think, so this says, when you have patients coming to the ER with an arrhythmia, do you normally discharge them with remote monitoring?
I think it depends on what you are looking for. We do that a lot. What is typically done, for example, we talked about our approach with event monitor studies. We will ship those out. And so if, say, the ER physician is concerned about somebody, they will message us or send a referral through our EMR system. And then, within 24 hours, they've got a device getting shipped out to them. So it really depends on the patient, what the clinical question is. Of course, if it's something acute, something serious, we would admit the patient, and then we might send them home without patient telemetry monitoring. But it really depends on case to case, but we do a lot of monitors from the ER. We will send them out through our EP clinic just so that they have follow-up in place. Initially, it was our ER docs was sending it out, but that's not the best to ensure reliable follow-up. So anybody that they're concerned with, we'll just do it through our clinic.
Yeah, and I think I would just add, I agree with John. I would just add that a lot depends on the arrhythmia, a lot depends on the history of the patient. So, if a patient's come in with syncope and they've had multiple workups for syncope and they've had negative monitors, they may get an implantable right there in the emergency room if it sounds like an arrhythmia, if it doesn't sound neurocardiogenic or things like that. But we use a lot of monitors as well, and we try to get the monitor done before if we can't get it placed in the ER due to whatever reason, then we've worked hard over time to develop this, but to make sure that there's just one phone number that's a call that's made, and to get that patient monitored. And it may be home delivered if we can't put it on them at the time. Especially if we have some warning, like they're held overnight in a clinical decision area, sort of a holding area, which we also use as a syncope unit and things like that, is that where people are ruled out overnight who are asymptomatic or no longer having symptoms, they may sit there and we would start the process of trying to get that monitor before they leave. So monitor, as I always refer to this when people aren't being monitored, whether it's from ER to home or hospital to home, or monitor over and deciding for a longer monitor, this black hole of monitoring. So we've worked really hard to try to prevent patients from falling into this black hole of monitoring where it just never gets done. And that's something that's been a focus that we've been putting a lot of attention to in the last 3, 4, 5 years, to the point where we have one phone number, a call's made, the monitor gets done.
Perfect. Okay, so then Chris, I'm going to turn it back over to you.
Okay, so hopefully you can hear me. Okay,
Yes.
Good. All right. So first of all, just want to thank you, Dr. Day, Dr. Rogers, for a great presentation. Want to obviously thank the audience for the really good questions. I know a lot of times questions will come to you later, and certainly we'll have a form to be able to answer those at that point. But also want to thank everyone that attended the call. All of the healthcare workers have been put under a lot of stress, particularly over the last several months, and we just can't thank you enough for everything that you do. I personally live with one. I've got my wife's an RN, BSN, so she's living in it too here in Michigan. But just want to thank you for everything that you do. I know all of us at Medi-Lynx appreciate it. If you can think of different questions, we can certainly get those to both Dr. Day and Dr. Rogers after this event. Over the next coming weeks, several weeks, Medi-Lynx staff will follow up with each one of you just to make sure your questions are answered, check in with you and see if there's anything that maybe we can answer for you. We were very proud to be able to offer this webinar today. I think it was really good, and it's a great way to, I think, reach people, especially in this current environment. I just want to say stay safe, stay healthy. This concludes our call, and I just want to thank everybody for joining us today. Thank you.
Thank you.
Thank you.